Bismillahirrahmanirrahim. Dear students, welcome back. We are going to continue today our series about sympatholytics by talking about their pharmacological actions, clinical uses, adverse effects, and contraindications of these alpha and beta blockers. Number one, we are going to start with the alpha adrenergic blockers, their pharmacological properties. Number one, the cardiovascular effects, the effect on the heart and blood vessels. Regarding the blood vessels, the normal sympathetic response is to cause vasoconstrictions of arterioles and venules, right? So the opposite will be vasodilation, right? Which will lower the peripheral vascular resistance and hence the blood pressure. They also can prevent the pressor effect of usual doses of alpha agonists, specifically the mixed agonists such as epinephrine. So epinephrine has effect on alpha receptors, which would cause vasoconstriction on the blood vessels, and has also effect on the beta 2 receptors, which will cause vasodilation, right? So if I block the alpha receptors by the alpha blockers, what would remain is the beta 2. So here you are converting the pressor effect, the vasoconstriction induced by epinephrine, into a vasodilator or the pressor effect, and this is called the epinephrine reversal. Okay. They cause reflex tachycardia and orthostatic hypotension. Let's take them one by one. Number one, non-selective alpha blockers cause tachycardia if blood pressure is lower because of two things. Number one, presynaptic alpha 2 receptors. Normally, without epinephrine, without norepinephrine, without anything, normally as we said before, norepinephrine, when it is released, it will go back and activate the alpha 2 receptors, which will inhibit further release of norepinephrine, right? If you inhibit these alpha 2 receptors by these alpha blockers, what would happen is that this effect is not going to occur, which means epinephrine release will be more, and this will stimulate the beta receptors in the heart, which will cause tachycardia and also increase in the contractility. The second effect will be the baroreceptor reflex, or baroreflex, which is, as we mentioned before, the decrease in blood pressure will inhibit the baroreceptors, and this will cause to send a message to the vasomotor center in the medulla oblongata, which will activate the sympathetic nervous system and inhibit the parasympathetic nervous system. This again will cause tachycardia. Okay. Okay, orthostatic hypotension due to antagonism of sympathetic nervous system stimulation of alpha receptors. So normally, the sympathetic nervous system, as we said, will cause vasoconstriction, right? If you don't have this vasoconstriction, so you cannot maintain blood pressure in the upright position when you try to stand up, right? And this will cause venous pooling in the periphery and orthostatic hypotension. In addition, this is on the veins level. So this is the venoconstriction, because the veins, they maintain blood pressure because they decrease the pooling of blood in the extremities, specifically in the lower part of the legs. And regarding the arterioles, also usually the sympathetic nervous system usually constrict the arterioles in the leg, which contribute to the normal orthostatic response. Both of these will be inhibited, and this will cause orthostatic hypotension. Regarding epinephrine reversal, just this is a little figure that shows the normal response of this. Remember phentolamine? Remember last time we talked about it? It's non-selective, yes, non-selective alpha blocker. So this guy, normally, because we need to measure these two, if you need to measure these two with each other, you have to measure this alone and this guy alone, and then you measure the two guys with each other. So the first player is phentolamine. Phentolamine is alpha blocker, okay? So before you use phentolamine, this is the blood pressure reading. You have to take first the baseline blood pressure and heart rate, And then look here, after phentolamine, the blood pressure decreases and heart rate increases, as we mentioned before. Okay, so regarding the alpha blocker, they cause reflex tachycardia. So this is kind of a revision to the previous lecture, right? And also they cause hypotension, or exactly they are used as antihypertensive. Then epinephrine alone. Okay, again, the baseline pressure. Look at after using epinephrine, the blood pressure increases, right? And the heart rate increases. This is normal because epinephrine stimulates beta 1 receptors in the heart, which will cause increase in the heart rate and contractility, of course. Now we can use both drugs with each other. Okay, now I start with phentolamine. Phentolamine will inhibit alpha receptors, generally speaking. So what's remaining for epinephrine is what? It's just the beta 2 receptors, right? So beta 2 receptors will cause vasodilation. Activation of these receptors will cause vasodilation. So there will be decrease in the blood pressure, right? So here, look here, the numbers. And there will be a reflex tachycardia, or we can say this is the decrease in the blood pressure, but tachycardia actually occurs due to the epinephrine itself, activation of the beta 1 receptors, okay, and the heart, of course. Other effects, again, remember the normal responses to the sympathetic nervous system. On the level of the eye, sympathetic nervous system activate the dilator pupillae muscle, which will cause mydriasis, dilatation of the eye pupil, okay, or widening of the eye pupil. So if the sympathetic nervous system causes mydriasis, the opposite will be what? Meiosis, right? Because you are blocking these receptors, alpha receptors in the eye, in the iris, or in the radial muscle exactly of the iris, or the dilator pupillae muscle. Again, the blood vessels in the nose also, they usually are vasoconstricted by the sympathetic nervous system. If you inhibit their alpha receptor, this will cause nasal congestion or stuffiness. Again, on the level of intestine, we see sympathetic nervous system inhibits the intestinal motility. If you use alpha blocker, the intestinal motility will increase, and this is because the inhibition of the relaxant sympathetic influence, diarrhea may occur. Sodium and water retention. They can cause sodium and water retention. This is because they will decrease the renal blood flow. The renal blood flow, if it decreases, this will activate beta 1 receptors in the juxtaglomerular cells, glomerular cells, and this will activate the RAS system, which will cause RAS is the renin-angiotensin-aldosterone system. This will cause at the end sodium and water retention. Okay. Regarding the bladder and the prostate, they are specifically alpha 1A receptor subtype is expressed at the base of the bladder and the prostate. So if you use alpha blockers, they cause resistance of the flow of the urine to the flow of the urine, and so the patients who has benign prostate hypertrophy, they usually have urinary retention. So if you use these drugs, the alpha blocker, they will facilitate the urination and will be helpful to these patients. Remember again, the normal sympathetic response of the vas deferens is the contraction of the vas deferens, okay, which will result in ejaculation, right? This coordinated through alpha receptor. If you inhibit, so instead of ejaculation, remember we said sympathetic nervous system induces ejaculation. So this ejaculation, the usual response will be inhibited by alpha blockers, specifically tamsulosin, when we talk about individual drugs. These drugs are used in specifically treatment of hypertension induced by or in patients with pheochromocytoma. Just as a reminder, pheochromocytoma is a tumor in the adrenal medulla that secretes a high amount of norepinephrine and epinephrine with subsequent severe hypertension. Here you can use phenoxybenzamine. I'm reminding you, like last time we talked about it, we said phenoxybenzamine is an irreversible alpha blocker, okay? Irreversible. So it binds to the alpha receptors, it does not dissociate, so it will be very effective. The effect will be very prolonged, so it will be helpful for these patients. They are used in benign prostate hypertrophy. Okay, as we said before, specifically tamsulicine. These drugs have alpha 1 blocker activity. Tamsulicine has alpha 1A, so it's kind of more selectivity regarding these receptors in the prostate and the neck of the bladder. So they are helpful in patients with benign prostate hypertrophy. They are used in hypertension like prazosin, terazosin, doxazosin. We remember last time we said osin means they are alpha blockers. They are used in management of hypertension. They are used also in migraine, like ergotamine is one of the most effective drugs for moderate to severe migrainous attacks. Okay, so side effects are expected: palpitation, postural hypotension, nasal blockage, diarrhea, fluid retention, inhibition of ejaculation. We already talked about these, but this is just kind of conclusion of the adverse effects. Then we now switch gears to beta blockers. Okay, the prototype is propranolol. Okay, remember this group, the beta blocker. We said the suffix lol is kind of distinct in these drugs. So it's the prototype to which any other beta blocker will never discover. New beta blocker you compare it with propranolol, it has more effect than propranolol, less, whatever, similar. Okay, it's non-selective beta blocker. It inhibits both alpha 1 and alpha 2. There are agents which are beta 1 selectives, including metoprolol, atenolol, acebutolol, bisoprolol. Okay, they are selective for beta 1. Some of these beta blocker have what's called intrinsic sympathomimetic activity. These drugs are what's called partial agonists. So they are not full antagonists. For antagonist or pure antagonist is propranolol does not have any capacity to activate beta receptors. But these drugs are kind of partial agonists. So if the agonist effect is like up here and the antagonist effect is down here, there is something in the middle or a little bit above the zero level. So if any drug plays in this area, we call it partial agonist. So these drugs are partial agonists, have intrinsic sympathomimetic activity. But their effect, of course, is less than the full agonist isoproterenol, isoprenolol. So isoprenolol will be like up here, propranolol will be down here. These drugs will be kind of here, have some little intrinsic sympathomimetic activity, can little bit activate the receptor, but not as high as the isoprenolol, the full agonist. Some of these drugs, including propranolol, acebutolol, carbidiol, have some brain stabilizing activity or called local anesthetic activity, similar to actually the lidocaine, the normal prototype local anesthetic drug. Okay, usually beta blockers do not affect alpha blockers. However, there are some of these drugs, including labetalol, carbidiol, bucindolol. They inhibit alpha 1 receptors in addition to the beta receptors. Some of the beta blockers have vasodilating properties, which will add to their antihypertensive effect by two mechanisms. Number one, we already talked about it, by inhibition of alpha receptors, which will help in vasodilation. Number two, by increasing the production of nitric oxide. We talked about before nitric oxide causes vasodilation. That's why these drugs, nebivolol, has a very rapid effect. The pharmacological actions, okay, take propranolol as a prototype drug. On the level of the heart, it's expected again. Normal response of the heart to the sympathetic nervous system is increasing heart rate, increasing force of contraction, increasing cardiac output, right? The opposite of that will be decreased heart rate, decreased force of contraction, decreased cardiac output, because as you know, heart rate times the stroke volume, okay, will give you the cardiac output, right? However, don't expect that these drugs are used like for arrhythmia or whatever. The patient's normotensive, the patient does not have hypertension, there will be no significant effect. The patient is under sympathetic activity, stress or running or any fight or flight response. These drugs will have this effect. They will decrease the heart rate, force of contraction, cardiac output. One of the good things about these drugs, that's the reason for these drugs could be used for heart failure, they decrease cardiac work, because now we are decreasing the heart rate and force of contraction, so the oxygen demand is decreased. Then the hyper, of course, they are antihypertensive drugs. Okay, on prolonged administration, blood pressure gradually falls. Okay, because they decrease cardiac output, as we mentioned. And the total, regarding total peripheral resistance, can be a little bit intriguing. In the beginning, there will be a little change because on one hand, these beta blocker will inhibit this response, right? Will inhibit this response of the sympathetic nervous system, which usually cause increase in the heart rate and cardiac output. So cardiac output will decrease, which is okay, which is good. The second thing, they will inhibit the beta 2 receptors, which will cause vasoconstriction. So the final will become, this will nullify the effect of this. So the final will be a little change in the blood pressure. Okay. However, with continued use, the resistance of blood vessels gradually adapt to the chronically reduced cardiac output. So the total peripheral resistance, which was the issue now, because here I'm inhibiting the beta 2 receptors, which would cause vasodilation. So the predominant effect will be only on the alpha receptor, which would cause vasoconstriction. So the blood vessels will kind of get adapt or to this continuing vasoconstriction, and total peripheral resistance then will, and also adapt also to the reduced cardiac output. Total peripheral resistance will decrease, and then both systolic and diastolic blood pressure will decrease. Other mechanisms that contribute to falling blood pressure, we talked about that decreased renin release from the kidney, because these drugs are beta blockers. If they inhibit beta 1, they will inhibit the production of renin by the juxtaglomerular cells in the kidney, okay, and inhibition of RAS, so inhibition of sodium water retention. Because, as we said, they also inhibit the beta receptors, the presynaptic beta receptors, which here cause in stimulation or the induce the release of norepinephrine. If you inhibit this presynaptic beta receptor, they will inhibit the release of norepinephrine. Yes. Central action, they reduce the sympathetic outflow, which usually causes increase in the heart rate and cardiac output finally. On the respiratory tract, remember the bronchi, they have beta 2 receptors. Okay, usually, again, the sympathetic response of the bronchi is to have bronchodilation, right? If you inhibit beta 2 by these drugs, the beta blocker, this will cause bronchoconstriction. That's why these drugs are contraindicated, specifically in patients with COPD, chronic obstructive pulmonary disease, or asthma. The beta 1 blockers, actually, they have some advantage. So that's why beta 1 blocker use is prevailing nowadays, because they have selective activity against beta 1 receptors in the heart, but not on the beta 2. But however, there is nothing absolutely selective. They can, if you increase the dose, or even in a small dose, they can have some little effect on the beta 2, not as beta 1, of course. So, so they could be used with precaution, or better avoided in patients with bronchial asthma. On the level of the eye, the beta blocking drugs will inhibit or will reduce the production of aqueous humor. Aqueous humor, we say, it contributes to the intraocular pressure. And so if you decrease the production of aqueous humor, you are decreasing intraocular pressure, and you can help with treatment of glaucoma. So I said before, I'm recapping here, I'm reminding you, parasympathomimetics are good for glaucoma, and sympatholytics are, specifically beta blockers, are good for glaucoma. The metabolic effects, they increase the triglyceride level and LDL HDL ratio. Okay. They inhibit glycogen. Remember, the level of glycogenolysis, we said adrenaline or sympathetic nervous system activates glycogenolysis. Okay, because I need fuel, right? I need glucose. So, so here this will inhibit glycogenolysis in the heart, skeletal muscle, and liver. But they reduce carbohydrate tolerance by decreasing insulin release. So these patients will have carbohydrate intolerance, specifically in pre-diabetic patients. the membrane stabilizing or local anesthetic activity, even though propranolol is as effective as lidocaine, but it's not used for this purpose because it's irritant. Okay, but this activity claimed to contribute to the antiarrhythmic effect of propranolol. This will help in the level of antiarrhythmic effect. On the level of the uterus, sympathetic nervous system called uterine dilatation through the beta 2 receptors. So these drugs will block the relaxation of the uterus in response to isoprenaline or selective. Isoprenaline, you remember, it's non-selective beta agonist, activates beta 1, 2, 3, okay, or selective beta 2 agonists, but the normal uterine activity is not significantly affected. Uses, it's easy now. We can use them in treatment of hypertension, angina pectoris. We remember we said they will decrease the heart rate and contractility, and this will decrease oxygen demand. So they will help in angina pectoris. Because they decrease heart rate, they could be used also for cardiac arrhythmias. Congestive heart failure, this is kind of little intriguing because in one hand they decrease contractility, which will aggravate the situation in heart failure patients. But research have said something fantastic about that. We'll see in the next slide, inshallah. They are also helpful in patients with thyrotoxicosis. They control the symptoms like palpitation, nervousness, tremors, severe myopathy, and sweating without significant effect on the thyroid gland itself. Migraine, the propranolol is one of the most effective drugs for chronic migraine prophylaxis. And glaucoma, we said, like Pymolol and other beta blocker drugs, they inhibit the production of aqueous humor, so they decrease the intraocular pressure. Okay, they use the adjuvant in angular closure glaucoma. Let us talk about the research here. This is research have been done in 2006, which shows actually the same we expected in the beginning. This is metoprolol, okay, and this is standard therapy. The x-axis is the time of the duration, and the y-axis is the left ventricular ejection fraction, which is kind of a readout for the cardiac function. So the more of this y-axis, the more contractility. The more ejection fraction, the more contractility. Okay? This is the baseline at 0 time. Here you see in day 1, there is a decrease in the ejection fraction. Then after 1 month, they were like similar, no significant difference here. But look at after 3 months, the metoprolol increased the ejection fraction, means it's helpful for heart failure patients. Actually, the name of the paper here is kind of interesting. Beta blockade in congestive heart failure from contraindication because of that to indication because of that. Okay, so these drugs are now used. Actually, the exact mechanism is not well known, but remember we said they inhibit beta receptors in the juxtaglomerular cells, so inhibit the RAS system, which will inhibit sodium water retention. They inhibit binding of norepinephrine and epinephrine to the beta receptors. Epinephrine and norepinephrine, they have mitogenic and pro-apoptotic activity. So this will be deleterious to the cardiac muscle. So these are just the proposed mechanisms for that. Adverse effects, bradycardia. Remember, the normal sympathetic nervous response is increased heart rate, the opposite tachycardia. Okay, but resting heart rate may be even response to about 60 beats per minute. Carbohydrate tolerance may be impaired, as we mentioned, for lipid profile because total triglycerides and LDL-HDL ratio is increased. This will enhance the risk of coronary artery disease. Tiredness and reduced exercise capacity because of the decrease in heart rate and contractility. Cold hands and feet because of the prevailing activity of the vasoconstrictor alpha receptors, because I'm closing the vasodilating beta 2 receptors. On the level of CNS, they cause forgetfulness, depression, sedation, and sleep disturbances. Precautions and contraindications include rebound hypertension. This is the precaution. Whenever you stop these drugs, you have to go gradually. So you have to do gradual withdrawal. Otherwise, there will be rebound hypertension. This will worsen angina, of course, because now there's hypertension, there's increase in heart rate, there will be increase in oxygen demand. This will hurt or aggravate the angina, and even sudden death could occur. They are contraindicated in asthmatic patients because I said they inhibit beta 2 receptors in the lung, which normally cause bronchodilation. They are contraindicated in partial or complete heart block. Heart block means that there is, in the conductivity of the heart, okay, which starts with the sinoatrial node. If there is a block in the conduction, this is called heart block. But then if you add to that the negative chronotropic effect of these drugs, means the effect of these drugs that decrease heart rate, this will be aggravated, which could lead to cardiac arrest. That's it for today. I hope you have enjoyed my lecture. Thank you, and please enjoy and say Subhanallah wa hamdih, Subhanallah al-Azim. Wassalamu alaikum wa rahmatullahi wa barakatuh.